continue with levodopa. So on and off periods. So it's a good graph here to explain it. So at the beginning of at the early stage of Parkinson, so you have the situation where there is normal dopamine level, where everything is nice. Then if your dopamine level is too low, then it's off state. You are, how to say, out of business. And then if the dopamine is too high, then you have dyskinesias. So if your dopamine, you administer dopamine, and the idea is to avoid going to this off state. So you administer dopamine, then it goes up. The half-life is very short. What do you think? What is the levodopa half-life? Half an hour, if I'm correct. I have to check. Yeah, it's a shot like that. So everything is okay. So you, at the beginning, you will give your levodopa to avoid it's going down. It goes up. After that, it will be destroyed. It's starting to go down. You will give levodopa. It goes up, and so it's okay. But this window becomes narrower and narrower with time. So what happens is that more frequently your levodopa is decreasing to the level where your dopamine will be too low, off state. And very frequently it goes up to the stage where you have dyskinesias, too much dopamine. It can't be avoided because this window is becoming narrower and narrower. You have less dopaminergic neurons left. But another problem is that the half-life of dopamine is very short. It fluctuates too much. Best would be to have something exactly in the middle, theoretically. So it's necessary to make the half-life of this dopamine or levodopa produced dopamine longer. So therefore this levodopa is nowadays always combined with dopa decarboxylase inhibitors, carbidopa benzerazide. So this prevents levodopa's conversions to dopamine in the blood. So you have a more dopamine going to brain, or sorry, more levodopa going to brain. This is one good thing. And another good thing is that this dopamine in periphery will induce also some peripheral side effects. You will get rid from that side effects because you don't have peripheral dopamine. So levodopa needs carbidopa together with it. And what is carbidopa exactly doing? It blocks this levodopa to dopamine pathway in periphery. It's not going to brain, that happens in periphery. Half-life is going to this 30, 40, 50 minutes to 90 minutes. So very much necessary. Another thing is what is used, but not so much maybe because of side effects, is catechol or methyltransferase COMT inhibitor. COMT inhibitor avoids this another pathway from levodopa to some kind of metabolite which is not helping. So you have again more levodopa, more dopamine. So you block the assays which are removing the dopamine from brain. You will increase its lifetime in the brain. It's good but not enough. Anyway, it's 90 minutes, 100 minutes. Plus these COMT inhibitors have side effects. So therefore, what happens is that producers, pharma companies are trying to produce the more lasting, how to say, extended release tablets or beads, so that if you have such kind of just levodopa, then it's somewhere here, fast peak, but you can have some versions, levodopa versions, lasted, okay, which are very long. In that case, you have your fluctuations. They are not anymore like that, but they are maybe like that. And what is also not much used, but there are pumps, at least available in UK, where you have with pump you can have a constant release of levodopa to bloodstream. It is similar to insulin pump. So insulin pumps are nowadays for type 1 diabetes patients. They are very popular. So the principle for this levodopa pump is absolutely the same. And then it's also not too much used, but in US it is this kind of inhalation powder is available, because if you are taking the pill, you are having this off episode and you want to go quickly from off to on, then the pill is slow. But if you take this inhalation powder, it's fast. So what to remember that you have this main problem is dyskinesias and in off situation, and it is in some extent predictable. So you will take your tablet, you know that now you are maybe in dyskinesia, then or maybe not, and then you know that after some time the dopamine is going down and you are off. And the people are frequently who have this serious dopamine, Parkinson's disease, they are planning their life accordingly. So I know one scientist who had a conference presentation, and he planned this presentation exactly so that it will be between this on and off period. He took the levodopa accordingly. After presentation, immediately he left the room, probably the problem started. So another drug group is dopamine agonists. So means that if you can't give more dopamine, you activate dopamine receptors to compensate the lack of dopamine. And there is two kind of dopamine agonists available. It's the ergolin or ergot-based bromocriptine. Ergot is the fungus which is growing on grains. And these non-ergot-based agonists, pramipexole, ropinirole, rotigiliotin. So the names are unfortunately, I'm afraid, Estonian. So it's bromocriptine, cryptine. So they are receptor agonists, but they have some difference. They are affecting different receptors, dopamine receptor subtypes slightly differently. But this is not so relevant. They are more or less working similarly. Maybe side effects are slightly different, but all would be used. The side effects compared with levodopa are quite different. So if you compare this table, what you have with levodopa, you have these dyskinesias, on and off symptomatics. With dopamine agonists, you don't have these symptoms, but you have a lot of other side effects, from edema to fibrosis, nausea, hallucinations. will just have another group of side effects, and they are not good. So, I mean, if you take levodopa and you don't have these problems, then levodopa is better for some period. So then there are MAO-B inhibitors. So it's also related to the same system. This monoamine oxidase B, MAO-B, is the enzyme which is breaking the dopamine down in this synaptic cleft. So you inhibit this enzyme, you have a more dopamine. Rasagiline, selegiline, safinamide are the drugs. So it's good. So you can use this drug in addition to other drugs, to levodopa, to have more dopamine. And sometimes it is used, especially it is used where this levodopa treatment is giving you such kind of on-off fluctuations. And then this new drug is istradefylline, which is adenosine A2A receptor antagonist. It's also used in combination with levodopa, carbidopa, and in patients where you have these on and off periods, where levodopa enough is not enough. And its mechanism is very indirect and complicated. So it's not much used, but its relevance is that it is one of the new drugs which came for Parkinson's disease after the 90s. Let's see, do we have something?
In the normal brain, movement is regulated via the direct and indirect pathways of the basal ganglia of the brain. Dopamine activation of the direct pathway promotes movement, while activation of the indirect pathway slows movement. Adenosine and dopamine play critical roles in regulating indirect pathway activity. Adenosine activation of the A2A receptor excites the indirect pathway, which promotes the slowing of movement, while dopamine activation of the D2 receptor promotes normal movement. Coordination between A2A and D2 receptor activities results in a balance of overall indirect pathway activity. Different from the normal brain in Parkinson's disease, adenosine stimulation of the A2A receptor overactivity, coupled with reduced D2 receptor function resulting from dopamine loss, causes overactivation of the indirect pathway, leading to abnormal movement. Studies have shown that A2A receptor expression is increased in the brains of patients with Parkinson's disease. Selective inhibition of the A2A receptor is a novel, non-dopaminergic approach that reduces overactivation of the indirect pathway. That, when combined with levodopa, which affects both indirect and direct pathways, may help to address off time in Parkinson's disease.
So, the summary figure then, that with the exception of this last drug, all other drugs are directly affecting the dopamine. So in the center we have the levodopa, which goes to brain and from which dopamine will be made, more dopamine. Then it is used together with carbidopa, which is in blood, to avoid levodopa to dopamine conversions in the blood. More levodopa goes to brain. Then in brain you have the COMT inhibitors and MAO-B inhibitors. These COMT inhibitors work also in periphery. Their aim is just to avoid the dopamine conversion to something else, to keep to have more dopamine. And then you have dopamine receptor agonists to have more reaction to dopamine. And this previous drug is the only one which works out from that system. As it was told, it's only non-dopamine drug. So few examples maybe. You know the rotenone. Rotenone, originally it's again present in some kind of plants in Amazon, and the locals are using it again to paralyze the fish. So it's toxin. And later it was discovered that it's really good pesticide. It's really good to kill mice and rats with it. But then they discovered also that in addition, how it will kill the mice and rats. It is inhibiting the mitochondrial respiratory chain, and after that the mitochondria produce, or not so functional, produce sort of ROS, and dopaminergic neurons which are more sensitive will die. So in addition to rodents dying when this pesticide was used, also the UK farm workers had more Parkinson because they had a contact with the rotenone. So it's the compound which is inducing Parkinson disease, and it's still used as a model in laboratory to induce Parkinson disease. Then another thing is that I don't know the other names, rain tree in English, soursop, it has a lot of other names also, and it is containing the toxin called anonacin. So I have an Estonian name, sorry, it's anonacin, which is also similarly to rotenone inhibiting mitochondrial respiration through the complex 1 inhibition, if I remember it correctly. And it is not toxic if you will eat it little bit, but it is maybe one of the reason, if you eat it too much, one of the reason for the increased prevalence of atypical Parkinsonism in Caribbean. So it's interesting that they are making from this rain tree a lot of food supplements that are popular in Western world, and these food supplements at least theoretically contain this anonacin, which is toxic. So it is inducing most likely this atypical Parkinsonism. So we had the Parkinson disease, what is the atypical Parkinsonism? So it's more or less the same, but not, so there is Parkinson disease and there is Parkinson disorders, Parkinson plus syndromes, which are slightly different. So there could be some difference in it. Some symptoms are similar to Parkinson disease, but usually they are fast and advanced symptoms come earlier. So what is difference is that sometimes levodopa is not helping at all. So if you go to the disease classification, you will find, in addition to this classical Parkinson, also these syndromes, atypical Parkinson disorders, and so on. Then what is also interesting is that some drugs, usually the drugs affecting or targeting central nervous systems, they may induce some kind of Parkinsonism. It's not exactly Parkinson disease, but Parkinsonism, atypical, drug-induced Parkinsonism. It's very difficult to tell how frequent that is. But this Parkinson Disease Society itself, they think that 7% of the Parkinsonism people with Parkinsonism have developed their symptoms following the treatment of such kind of drugs. So there is also drug-induced Parkinsonism. So this is all I had about Parkinson's disease. Now it's time to have some questions again. What you can ask, please. So
You have mentioned about microphagia and autophagia.
yes.
So how come it is? So it is a recovery process. Like it's like removing unwanted or unwanted mitochondria or damaged mitochondria. Autophagia and mitophagia.
Yes.
So how is it specifically for Parkinson's disease?
So it's we have some this early onset Parkinson disease forms which are induced, which are caused by PINK1 and Parkin mutations. They are absolutely directly related with deficient mitophagy. So the deficient mitophagy, I will later in future lectures explain it in more detail. This deficient mitophagy is the main reason for this Parkinson disease in these specific cases. If we take the alpha-synuclein, how to say, related sporadic Parkinson disease, then we do not know whether the mitophagy is secondary or whether it's partly primary also. Most likely it's somewhat secondary, we do not know. But there are specific cases where mitophagy is the primary reason.
Same related doubt. Like if you are targeting say mitochondrial biogenesis or mitochondrial mitophagy. So if you are targeting follicular.
Okay.
So
Yes.
how can you specifically target the same region?
So there is no way to induce mitophagy specifically, at least we don't know the way, but there was theory that if you in general induce autophagy, for example with rapamycin, which activates through mTOR the autophagy, then the removal of the bad stuff, including mitochondria, increases. So they have done a lot of studies with rapamycin, but at the end the idea, okay, it was not wrong, but it has reached to nowhere. So if you induce unspecific a lot of autophagy, it's not good enough to help. So another question was mitochondrial biogenesis. This is theoretically good. If you activate mitochondrial biogenesis, you will get a lot of new mitochondria. But will it help? These old bad ones are not going away. They are going to produce a lot of free radicals anyway. And we don't have any good pharmacological compound to induce mitochondrial biogenesis. So I hope it is okay. But
So there are few organisms which have regenerative capability. They can regenerate their neurons.
yes,
For example, sarcophagus. So
yes.
it has neural glial cells which are pluripotent. They can transform into neurons. So is there any possibility you can use our glial cells which are in their brain
Okay.
to differentiate into neurons or something?
So I do not have clear answer. So if you think about this, you need somehow to introduce these cells to the brain. So if you will inject them stem cells or whatever cells to specific area, then the problem is that they don't want to integrate the system very well. They are remaining there, but they don't. If you take these dopaminergic neurons, they will have a synapses with other neurons. Something activates them, they are activating something. If you will put in some new cell, inject it, it remains passively there.
Cells which are already residing there. So
Cells producing dopamine, you mean?
no, only glial cells.
So what do you exactly mean to put microglial cells to brain?
We can induce them in such a way.
Okay. I don't know. Usually the microglia is problem showing that there is inflation. Well, I don't have a good answer to your question, but usually these injections they do not work. Injection of some kind of cells is not working. What they are trying to inject growth factors, BDNF, to the brain, and some other components, MANF and some other growth factors, with hope that these growth factors are inducing something good or activating the stem cells there or something. More questions? Okay. Then multiple sclerosis, sclerosis multiplex. This is now quite different disease. This is related to inflation. And if you remember this earlier slide where we had the prevalences and expected life or life expectancy, then it was written that sometimes it's normal life expectancy. And this is the disease where we have a lot of drugs, and these drugs are not just symptomatic, but they are really disease modifying drugs. So what is different is that it's autoimmune disease. For some reason, immune system destroys the myelin sheath surrounding the nerve cells. And this damage is having a lot of very different symptoms. So if you are checking the list from fatigue to vision, speech, muscle weakness, pain, diarrhea, urinary incontinence, so on. And in the figure, you have even more problems listed. So it affects everything. All neurons that lose the myelin will have problems. At the beginning it's not visible, but if the damage is strong enough, then the lesions can be seen on MRI. And this is now disease where the prevalence is quite different in different countries. So you will see the highest prevalence, the red, in North America. It's more than 100 per 100,000. And then you go to India, it's almost 0 to 5 per 100,000. So it's huge variability compared with Western countries, with Asian countries or South American. So it's the European or it's Western disease. And the pathophysiology, we don't go to details. Pathophysiology is that somehow the T cells infiltrate to the central nervous system, and the inflammation they induce destroy these myelin producing cells, oligodendrocytes there. So the mechanism is more complicated, but for us it's not relevant here. So, and you can have a very different outcome from that. The disease progression is absolutely variable and different. So you have a relapses, you have progression, you have remission. So relapses means that everything is okay. Here it's disease progression. And then you have a sudden worsening, relapse. And then everything becomes better, you have remission, it goes back to normal. And so if it is going like that, it's relapsing remitting form. Or it could be progressive. So it's just going worse and worse. And then you have a mixes. It's secondary progressive, progressive relapses, and so on. A lot of different types. If you take the drugs, then the first drug that came 1993 was interferon 1 beta, and then after that others started to come. So interferon 1 beta, so they both 1 beta and 1 alpha, what they are doing, they are relatively unspecifically blocking the inflammation. So again, not going to details, but there are all these mechanisms here. This means that T cells become less activated. T cells are going not so efficiently to the brain. Then the antigen presentation in brain decreases. Production of anti-inflammatory cytokines increases and pro-inflammatory decreases. Beta cell proliferation decreases, and everything this means that inflammation goes in the brain, goes down, and oligodendrocytes have a less damage. So it's working okay, not perfect. So you see here the placebo, disease is progressing, and then this Avonex, which is beta-1 interferon, 1/3, progression goes down 1/3. If you take another study, then you see that it's quite different, but it's 1/3 reduction of mortality. Okay, but nothing very much special. It's the basic. Then we have a lot of different other drugs. It's glatiramer acetate, which is random polymer of 4 amino acids found in myelin. How it works exactly is not clear. Maybe since it's close, similar to myelin, maybe it somehow attracts the acts as a decoy, and these cells will be less aggressive against the real myelin. Nobody knows exactly, maybe again it's not relevant. There is some kind of improvement. So I don't know what the relapse rate, 1/3 going down. Then there are a lot of antibodies coming in. When previously Alzheimer, Parkinson, we had very rarely in Alzheimer people used antibodies, then here antibody is much used. So it's different antibodies. Just quickly going through what they are doing. This alemtuzumab is directed against the protein, glycoprotein CD52, that is on the surface of T and B lymphocytes. What this means, it will attach to the and B lymphocytes, and it will kill these lymphocytes. So different ways, but at the end you have less lymphocytes to induce inflammation. And then CD20 antibodies, they bind to CD20 protein, which is on the surface of B cells. B cells will die away. Or there is CD25, which is part of interleukin-2 receptor. So with that you will block the T cells. So the idea of these antibodies, these specific antibodies, is just to suppress or kill the B cells or T cells to have less inflammation. But then there is also the fourth antibody, which is more interesting, natalizumab. So it is against the adhesion molecule alpha-4 integrin. So this is different slightly because this specific integrin is required for leukocytes to move from blood to tissues. And if you have less of active integrin, then it's not anymore happening. And when you check when it's used, then you see the differences. So it's used for active relapsing remitting, multiple sclerosing, relapsing form, relapsing multiple. So they have all slight differences for against what type of MS they could be used. Okay. Then in addition to these antibodies, there is fingolimod and siponimod. So they are against very aggressive and active relapsing MS. So what they do is that they will cause internalization of sphingosine 1 phosphate receptor, and the lymphocytes can't anymore go out from the lymph nodes. If they can go out, you have less lymphocytes in blood everywhere, less inflammation. And then you have strong drugs, which is dimethyl fumarate. It's antioxidant. It's activating GAP1 NRF2 pathway. And if you activate this pathway, then you will get a strong anti-inflammatory response as well. And then it's two compounds, teriflunomide and cladribine, which blocked pyrimidine synthesis, or adenosine analog, which blocks also DNA synthesis. So these are, in principle, you block the DNA synthesis to avoid the T cell proliferation. So they are very strong, and they will affect not just T cell proliferation, but everything will be less proliferating. So to summarize, we have gold standard interferon B, which is suppressing unspecifically respiration. We have this clatirame acetate, which is similar to myelin, and maybe because of that suppressing T cell activation. Then we have a monoclonal antibodies to kill T and P cells. And then we have inhibitors of lymphocyte traffic. So the lymphocytes will not go anymore somewhere to induce inflammation. Antibody sphingosine 1 phosphate receptor modulators. Then we have one antioxidant, which is very generic, and very generic DNA synthesis inhibitors to suppress inflammation. So, questions about MS? So it's not so relevant in India, but yes, please. No, I don't know why it's high. So it's an autoimmune disease. So one possibility, because we have a lot of autoimmune diseases, not just MS, but others as well, Crohn's disease. And so that asthma is very high in Europe, in Western, that this is somehow related to the Western lifestyle, that autoimmune immune system becomes activated too easily, and we have autoimmune diseases. But I do not know. I think there is no clear explanation for that, just speculations. Yeah, it's also possible that immune system, there is genetic background which allows the immune system to be activated more easily. it's possible, of course. What do you think? Is it neurodegenerative disease? Because it really starts from the overactivation of immune system, and then the first cells which are killed are oligodendrocytes, and only after that, at the end, maybe neurons will die. Is it neurodegenerative? I mean, simple people and like me, we are considering it neurodegenerative, but I'm not sure whether this disease classification consider it to be close to other diseases. But I think generally it's neurodegenerative disease, but very, very different, and a lot of available drugs affecting this initial point, inflammation. Okay. Then still time for Huntington disease. Okay. We have.
No, I think we can wind up.
Yes. Sorry.
We can wind up. I think 5 o'clock.
So what you
We'll
prefer?
start tomorrow at 9:30 now.
Okay, it's also we can continue tomorrow if it's
Yes.
okay.
Yes.
Okay.
At 9:30.
Yes.
So for tomorrow, please reach at 9:30 in the morning, 9:20 in the morning, because after attendance we immediately start at 9:30, and